Good morning, good evening, everybody. Welcome to this IAS webinar, the first in a series about COVID-19 and HIV. This first one is really framed about what you need to know and a state-of-the-art update from three experts in terms of where we are today and what we know about COVID-19 and HIV. We're expecting a record-breaking audience for an IAS webinar today, so thank you for joining us. And just to let everybody know that the recording will be available as soon as possible and later this afternoon, we hope. My name is Dr. Lucy Stackpole-Moore. I'm the Director of HIV Programs and Advocacy with the International AIDS Society, and I'm delighted that you've joined us today for this webinar. Our aim for this discussion is to provide an opportunity to share the latest information about the pandemic and have a deeper look in particular at how it impacts on people living with HIV. We'd also really like to celebrate and applaud the work of healthcare workers, researchers, policymakers, and many of whom are IAS members, in fact, who are working tirelessly across the world to share their expertise that they've gained over many years in the response to HIV to be flexible, to be innovative, and to be effective in response to this new global pandemic. We are connecting, and the reason why we've chosen this time this morning is to really connect our colleagues in Asia with colleagues in Europe and Africa, and a bit later on today through the recording with colleagues in America, to really connect the expertise and the knowledge and the ingenuity, if you like, across the IAS membership. And look at how we can boost and encourage and enhance as the evolving response in terms of health, economic and social justice, the needs that are evolving every day that are caused by or accelerated by COVID-19. And as we know, just this week, this is a pandemic that touches very close to home, and we lost a dear friend and colleague, Peter Ramji, in South Africa. I'd like to welcome our three speakers for today. Dr. Meg Doherty, the Director of Global HIV, Hepatitis and STI Program with the World Health Organization. Professor Anton Pozniak, the President of the International AIDS Society and Consultant Physician and Director of TB Services at the Chelsea and Westminster Hospital in London, United Kingdom, and the Professor of Clinical Research at the London School of Hygiene and Tropical Medicine. And Dr. Olivier Nawaj-Chikung, Senior Resident HIV and AIDS Consultant with the Geneva University Hospital, HUG, here in Switzerland. Welcome to all three of you, and a special thank you today given the pressing and demanding calls on your time at the moment. We have a couple of housekeeping rules just to run through, and please note that given the vast number of attendees, we have 500 on the call today. Everyone is muted, and do please share your comments in the chat box if they have any technical issues or questions in response to the presentations in the Q&A box at the bottom of your screen. We have planned a 30-minute session at the end for question and answers, and time allowing, we'll have the space for one or two clarification questions after each of the presentations. You can also send questions via email to coronaquestions@iasociety.org. That email will be monitored throughout the webinar. I'd like now to hand over to our first speaker, Dr. Meg Doherty from WHO. As I mentioned, Dr. Doherty is the Director of the Department of Global HIV, Hepatitis and Sexually Transmitted Infections with WHO. Prior to her appointment in this role in February 2020, Dr. Doherty was the Coordinator of Treatment and Care in the department, and she's had that post since September 2012. She has more than 25 years of experience working in HIV and infectious diseases, including leading WHO's normative and programmatic work focusing on expanding HIV treatment to all and reducing inequalities in access to the most effective antiretroviral drugs for people living with HIV. She brings many years of diverse country experience to this role, having spent 10 years living and working in low and middle income countries, advising ministries of health and international partners on implementing comprehensive HIV and infectious disease programs. Over to you, Meg. Thanks for joining us today.
Hey, good morning, everyone, and I really do hope you can hear me well. I saw some comments that we already needed to speak up a bit, and I'll do my best to speak up. And I wanted to thank the IAS for allowing me and having WHO present, and to present first off because this is an extraordinary time. It's unprecedented. And I believe that what I say today will change tomorrow. And so it's very good to have this opportunity to share this information with you. So next slide, please. So just recapping the last 3 months, and as we go into the next 4, we know that a pneumonia of unknown cause was detected in China in late December. WHO since then has had a incident management team working 24/7 to be able to monitor and provide updates regularly. It was declared a public health emergency of international concern at the end of January, and mid-February became announced as a pandemic. As of the last evening, April 2, in terms of confirmed cases, we know we have from the WHO websites over 900,000 cases. And if you look at other websites, we've tipped 1 million cases, with between 45 now on the WHO sites, but over 50,000 deaths. And it is truly a pandemic where we have it affecting over 205 countries. Just to note that WHO and partners around the world have really quickly set up monitoring systems. And I wanted to give you the websites where we have our official WHO information, guidance, and guidelines. Next slide. And this is what you will see from the site rep that is produced every day to say, what is the burden of COVID and which countries are reporting? And as you can see, we know already that Europe and the United States have really been the hardest hit thus far, but we're bracing ourselves for even larger scale pandemic and infections to be seen in low and middle income countries. Next slide. Every day we look at the epidemic curve, and I think what you can see from this in the orange is the Western Pacific, primarily led by the outbreak in China, and then certainly followed by the outbreak in the European regions, and as you can see, the Americas, and a very small amount now coming in from Africa and other countries and Southeast Asia. And those are the areas that in particular, WHO is looking at, because we know that these are more fragile health systems, and it's unclear how these systems will be able to cope with COVID. Next slide. And when we look at this also, we look at the epidemic curve by the WHO regions, and you can see that it's only in one region, in China, and also in other areas where we've really seen the flattening of the curve. And in many places, we're just starting the epidemic curve upwards. Next slide, please. This, I think you've probably seen from information that you find on the web, but clearly we know that the age range, the infection is attacking all age ranges in what looks like a bell-shaped curve, with much fewer persons being reported in the younger age range, although we do know that children have been infected and may be asymptomatic, and we know that more and more as we have more infections, we're going to hear about infections happening in children, and there's been some recent deaths in very young children, 7 months, and another 13 years old. But prior to that, the only death in a child was age 14. So even though we have a bell-shaped curve, next slide, what we do see from a group in the European area is that the deaths are primarily in those who are over 60, over 70, and over 80 years old, with the predominance for male being affected more in terms of death. Next slide. So considering this pandemic and that epidemic situation, what has the WHO been doing? WHO has a COVID-19 strategy. It is currently being updated. And I think the key about how WHO, our Director General, and those leading the emergencies program has been that they try things and they're very adaptive and looking for solutions that would be differentiated for each of the regions in each of the countries. The goal here is to really save lives, minimize disruption of societies, and protect economies. And they want countries to be prepared. And you have probably heard that WHO has been saying test, test, test. And I think this has come up differently in different countries where they've adopted some of the WHO guidance in different ways. We definitely have defined transmission scenarios. We call them the 4 Cs. And the those that are at 3 and 4, where there's local transmission and experiencing clusters, they need a much more intensive approach. Next slide. What we can learn from the China response, where they were able to flatten the curve, and I'm sure you've heard about what is this term, flattening the curve, and essentially by using universal precautions, the PPEs that we've talked about, the personal protective equipment, aggressively finding cases, isolating them and managing them, having close contact quarantining, suspension of public gatherings, and really doing what we call now, rather than social distancing, but physical distancing. And that's an important term because people are still using the terminology social distancing, and we know that it's not really about removing social interaction, but it's really about reducing the physical space between people to reduce onward transmission of the droplets, and movement restrictions. And when you're in the 4 C's, when you're already at community transmission, there is a need to institute all of these measures. That's what China did and was able then to flatten the curve. We have not yet seen that happening clearly in Europe, and certainly we're on the upswing and the uprise of the epidemic right now in the Americas, where it's doubling very quickly in what we would expect as in this kind of situation. Next slide, please. We also know that the severity of the profile of COVID is differential, that we will have many mild and moderate cases and some severe and some critical cases. But we do know that those who could present with mild can end up in critical condition and needing ventilation and or dying. So it doesn't mean that one stays in this category the entire time. Next slide. So where can you find information and guidance? And I would have to say there's been a plethora of information, good information coming out from WHO, and not only from headquarters, but also from countries and from the regions. I will suggest that you go to the WHO website. Here is one site called EpiWin, where they're really looking at what we call risk communication and helping to combat the infodemic or some of the negative or incorrect information that's coming out. And here you would see information about the health sector if you are all working in the health sector, and there will be various trainings and other information that you can use there. Please tap again. And in those, you will also see sets of slides that will give these insights that you can share with your staff and as you're working, in terms of what to expect with mild versus severe cases, what to expect in the epidemiology. And we know now, as we learn today and as we learn more, there's going to be even more information as people are kept alive in critical care. And so more to come. Next slide. Going on to the topic of COVID and HIV and antiretrovirals, right from the beginning, there was quite a bit of comparison to both MERS and SARS, because at that time we knew that there were some countries that opted to be able to use the antiretrovirals, in particular lopinavir, ritonavir, or Kaletra, to treat or to prevent some of the coronaviruses. So we have set up a question and answer on our website, and please go ahead and take a look at that. We're trying to answer some of the main questions. Can antiretrovirals be used to treat COVID? And are people living with HIV at increased risk? Next slide. And what we know so far is not very much, meaning that we have a lot to learn about COVID and HIV interactions. We have only had a very few case reports coming out of China now about co-infection, and what we have seen is currently in the case reports from Zhu, Gao, and Zhu, that these have been relatively mild disease. And in one, the Gao report from China, low CD4, and those who had higher CD4 had similar outcomes. So it's unclear, and certainly with small numbers, we're not able to say very much. But there is a concern that anybody with severe immunodeficiency and or other comorbidities, which we know many people living with HIV have, they can have both hypertension, diabetes, pulmonary disease, previous infections, and also tuberculosis, that could put them at increased risk of having a severe COVID course. And we also have known that from the SARS time that persons who were infected with HIV and having antiretrovirals were not infected with SARS, leading some to think that the antiretrovirals could be active against coronaviruses. So much to learn. Next. So what we have done at WHO is we've gone ahead and we, not only for HIV and antiretroviral medicines, but we have a group that is using AI or artificial intelligence and people to look at every article coming out across the world every day. We did a very quick review on the antiretrovirals and whether or not they have benefit for prevention and treatment in COVID. And we've also looked at all the registered trials, and we'll be updating this regularly. Next slide. And what we've done so far is we've produced the first version of the paper, and we're already in process of updating it. And what we know in terms of the efficacy and safety of ARVs for the treatment and prevention of SARS, MERS, and COVID is that we have 22 observational studies, most using lopinavir/ritonavir. And overall, and we have one randomized controlled trial with severe COVID using lopinavir/ritonavir that was reported in the New England Journal. And even though mortality was numerically lower in the lopinavir/ritonavir group compared to the control group, there was no statistical significance. And it's unclear if this would be something that could be benefited from patients, although we know that in the case of when people are severely ill, people look to any possible medicines, and there are now ongoing trials to be able to assess this in a larger number of populations and patients. There is some possibility or some hint that potentially lopinavir/ritonavir could work as prevention, but in the data that we have so far with SARS and MERS, the evidence was very low. And so we can't be recommending this at this point in time. Next slide, please. And this is just showing you the data from the New England Journal trial. I think you can look at this at your leisure, but I do think that it's important for us to know that this did not show greater protection versus standard of care. Next slide. So we know that there are many drugs that are being used either in trials right now or in compassionate use. We have remdesivir, protease inhibitors, including darunavir, atazanavir, and of course you probably have heard about hydrochloroquine and chloroquine, and the immunomodulators, in particular interferon alpha B2. We know in many other places, certainly in Italy and the United States and other antibodies and other immunologicals to be able to address this. Next slide, please. So the WHO has launched what we call the Solidarity Trial. It was launched last week. It provides a simplified procedures to enable hospitals around the world to participate. They're looking at 4 different drug combinations: remdesivir, chloroquine, and hydrochloroquine, lopinavir, ritonavir, and interferon beta. We already have multiple countries signed up, and I would add Italy to this, and South Africa. It's important because South Africa may be able to help us know more about HIV and COVID. Next slide. And I just will direct you to a science page where you can find all the international clinical trials, all the updated research, and it's updated every single day. Next slide. I also just want to point that, you know, around the world, if you look online, you'll see that many hospitals, especially those that are hoping to care for very severe ill people, are bringing in some of these other immunomodulators. When we have enough information, and WHO would certainly be able to look at those. I think the challenge is these drugs are incredibly expensive, and those who might benefit from them around the world may not have access. Next slide. I also want to let you know that WHO, somebody asked me to share the guideline or guidance, and just to say this is an unprecedented time for WHO. We have guidelines and guidance going up every single day. And so I want you to go to the website where we have surveillance, clinical care. We've been involved in the HIV, hepatitis, and STI department in helping to develop some of the recommendations for clinical care. And that, I know there were many questions about women and pregnancy, and you would find the information there. There's information about logistics and certainly laboratory. They're bringing in all the new elements around not only NAT testing, nucleic acid testing, but how to start looking at some of the expert and the point of care and other tests. Next slide, please. And just yesterday, these were the scientific briefs that went up as well. So keeping in mind, you can look at this every day, and certainly the use of off-label medicines is something that's quite important, especially for those countries who may be facing lopinavir, ritonavir, either stock shifting to care for COVID. Next slide. This is an example of what the clinical management guideline looks like, and it's been updated already 4 times. Please click through. We have made a recommendation not to use steroids. Click through. And we have a section for caring for pregnant women and children as well, and what to do during birth and also in the postpartum period. The one thing to say is very soon there will be a new review up around the risks or not, or lack of risk potentially of using NSAIDs or ibuprofen in terms of acquisition or severity of COVID, and also looking at the ACE inhibitors. I think early on in all of this, there can be ministries of health even working on small amounts of data and suggesting that we avoid certain drugs. And so WHO is taking it upon themselves to do the reviews, and those reviews will be ready very soon. And just to say, it doesn't look like there should be any stopping of current medicines for either NSAIDs or for ACE inhibitors. One should continue on their medicines. Next slide, please. We also have just put out on Friday and Monday this week of the big new question as the virus moves into low and middle income settings and settings with fragile health systems. How do we maintain essential health services? And it's about how to, one, plan for country preparedness, but also make sure that MCH, HIV, other essential health services continue, because there could be death and morbidity from these medical conditions if they are not maintained. Next slide. Again, we also have guidance on what to do with immunization and mass health interventions. Next slide. We also are starting to look and putting together a document to add to our Q&A about how do we maintain essential prevention services and contraception services. You've probably heard that there's going to be a condom shortage. So we want to continue those condoms, contraception, ensuring that methadone programs are available, and if they can, take home methadone as well. Next slide. We're looking at opportunities to see how we can use differentiated HIV testing, such as self-testing during this time, so that we don't lose any gains in sort of our 90-90-90 targets, and that we really do move to more home-based approaches. Next slide. And we have already made many recommendations around using differentiated service delivery, and there are many benefits, and this is the time where we need to step this up. Next slide. Where we are saying that we should recommend that people have 3 to 6 month clinic visits, 3 to 6 months ART refills, and have ART maintenance and support through the community. So this is an opportunity where HIV can actually support how we take care of people in the community for COVID, but also for TB and also for other chronic diseases. We would advise using multi-month dispensing, but we would avoid the group meetings and the CAGs and the adherence groups. Next slide, please. And for diagnostics, it's a rapidly changing sphere, but for HIV, we know we have very strong lab networks that have been able to do nucleic acid testing. And so many of those labs are being repurposed to be able to do the COVID NAT testing. But we want to continue early infant diagnosis, tuberculosis testing, and viral load. So there's going to need to be some guidance, and we already have that out. We're very excited about the expert, but it unfortunately appears that the expert cartridge for COVID does require a BSL-2 facility, meaning a hood for biosafety. So this is going to be difficult and needs to be worked out over the next several days to weeks. Next slide, please. For surveillance, there are multiple health information systems up and running, and they're looking and checking on the case-based form so that we get information. And just to say that the DHSI-2 has already been adapted to be able to gather information on COVID. Next slide. And just pointing you to a recent regional health systems response monitor coming in from the European region, where you can actually compare the responses and compare the policies across countries to see what's working. Very exciting website. Next slide. Lastly, we're tracking essential medicines. It's a real concern. Are we going to have stockouts? And I just want to point to you right now, currently in early days, we didn't feel we were going to have any major stockouts. Now, as this progresses, we're going to be watching very carefully how the generics are going to handle this in India, and there may be challenges where we're going to have to address these, but we have a team that's working on this daily. Next slide. And they look at a global level, all the supply chain, and there's a response. And I think now we know that we also have to start looking at food and food security and safety for those low and middle income countries. Next slide. And this is just to say that there's a supply chain cell working on all of these, and hopefully we'll start to see this effect once we have more of the actual PPE and products available to get out. There are teams ready to ensure the supply chain is maintained. Next slide. Just next slide. I think ending up, I want to give you a few hints as to what WHO does in terms of preparedness and how it's looking at low and middle income countries. This is sort of where we're looking at what is the preparedness around the world for countries. And I would say that the community engagement response may not be as high as it ought to be. And certainly we know that we have a gap between what we need for PPE and what's available. Next slide. And there's also many other fora, through Partners Fora, through UN, and this UN Challenge and Solidarity Fund and funding has really been extraordinary. All of that money that is coming in is going to country to be able to support and shore up their preparedness. Next slide. In Africa, we're concerned, and they've moved from readiness to response. Next slide. And as you can see, the majority of the cases so far are in South Africa, but they're ramping up across West Africa in particular. Next slide. And this is just a slide to say, what is our readiness in Africa in terms of hospitals, ICU beds, isolation units, and we're far from having what we need. And there's swaths of area that are just not reporting any of this. Next slide. So they're building on regular preparedness and bringing in all partners to be able to address COVID as it is rolled out or as it occurs in the African continent. Next slide. And I think similar issues will be faced in places such as India and others. So I want to let you know that daily the DG is online taking questions and sharing information. Next slide. And we now have several apps and chat bots Next slide, please. That allow you to get information right away, especially for people who do not have internet. Next slide. I think I want to end by just saying we know a lot of the medical information, but probably the information that's been most wanted and desired by people around the world is how do we address our fear, our stigma, discrimination, anxiety, and we have quite a bit of resources there. Next slide. And just to say that we need at this point, and you are all, I'm sure, part of this HIV community and civil society, whether you're a clinician or an interested party, but we have a huge amount and a huge role to play either electronically and or in your countries to help reduce stigma, to ensure that the civil society and communities are engaged, because there's quite a bit that we can learn from you and the HIV experience. Next slide. And with that, just to end on saying the situation is dynamic. We have real-time evidence. It's unprecedented for a coordinated effect. We can learn from HIV and the Ebola and other disease outbreaks, and I believe the next speaker will speak about other disease outbreaks, and community engagement and rights really have to inform the response. So with that, thank you very much.
Meg, thank you so much for that really interesting update. And I really wanted to pull out the word you said around unprecedented and some of the incredible examples you've given about timely access to innovation, information, and the innovations in terms of diagnostics and testing and even sharing of data and surveillance, just to respond, as you said, in this rapidly evolving context. Just to say, we remind everyone we do have the opportunity now for 1 or 2 questions of clarification, and to please post those in the Q&A box that you'll see at the bottom of your screen. We have had one come in already that's specifically in relation to your presentation, Meg, asking if we should all refer to physical distancing now instead of social distancing, and is that the language that WHO is recommending?
Thank you. Yes, last week, I guess WHO is always trying to rebrand things, but I do believe that, yes, that's what we're saying now. And almost all of our documents, we're switching over to physical distancing because it's about space between people, and concerning about you know, the message of social distancing. We're not trying to reduce our social connectedness. And certainly, I think in this time, through you know, through internet and other approaches, we've been able to be very socially connected. So thank you.
Thanks, Meg. And one more question in relation to your presentation was just around the topic around stockouts or drug shortages. And the question is if there are any strategies in place to mitigate against the risk of drug shortages.
So I think this is something that our team is currently working on daily, and they follow. First of all, there was a concern coming from China when the factories might have been closed. Would there be a lack of what we call the API, or the starting materials that are needed for drugs? And these are not just HIV drugs, this is drugs across the board that are these parts of the starting materials, would they be available for the Indian generics? And that they didn't have any problem with that, and there was adequate stock for 3 to 6 months back in February. Now that we're getting close to having India on lockdown, I think there's a greater concern and keeping eye on what might happen with specific drugs. Currently, right now, we're not seeing any major problem. We are potentially looking at what might happen with the lopinavir, ritonavir. We are seeing that that is one area where we have to keep an eye on, but there's no major challenge as of right now. Thank you.
Great. Thanks, Meg. And one last one for you before we shift over to the next presentation is to ask if or what is the WHO position on masks for all?
Thank you very much. A very easy question. I say that in tongue in cheek because I think WHO has certainly been asked to state, because our position has been that masks are, one, it's been a limited commodity right now around the world, and so therefore we want to be able to use this commodity where it's needed most. And we want our healthcare workers to have masks to be able to be protected. And so we have said that masks should be used for healthcare workers, for persons who have symptoms, who want to reduce onward transmission to others, and accordingly, you know, the right mask in the right kind of situation, with a surgical mask and eye protection for droplet protection in most cases, and then only airborne protection and N95 in the cases when procedures might aerosolize the droplets, such as intubation or doing a bronch or something like that. I think there's more and more concern about whether or not all people, because of asymptomatic or very mild symptoms, should people be walking around with the masks. And because of that concern, WHO is redoing and relooking at their review, and I know they were working on it yesterday. So I would expect information to be available in the very near future should WHO make any changes there. Thank you.
Terrific. Thank you very much, Meg. Now moving on to the second presentation, it's my great pleasure to introduce Professor Anton Pozniak, the President of the International AIDS Society and a consultant physician in HIV medicine at the Chelsea and Westminster Hospital, and Professor in the Department of Clinical Research at the London School of Hygiene and Tropical Medicine in the United Kingdom. Anton became a Fellow of the Royal College of Physicians in 1996 and a life member of BIVA, the British HIV Association, in 2014. He's a governing board and guidelines committee member of the European AIDS Clinical Society and the president of the European AIDS Trial Network, NEAT-ID. He has been an advisor on HIV and AIDS to the UK Government Health Select Committee and member of the Expert Advisory Group on AIDS for the UK Department of Health. He was the DSMB chair of the PROUD study and is the current DSMB chair of the MRC Odyssey and SMILE studies. He is the principal investigator for a 5-year test and treat project in Tanzania and a board member of the charity Quam UK. He has published over 400 peer-reviewed papers, mainly on clinical aspects of HIV treatment and care and HIV-associated tuberculosis. Thanks for joining us today, Anton. Over to you.
Thank you very much indeed, and it's a great pleasure to be here this morning or this afternoon, whichever your time zone is. I'm going to talk about global health systems preparedness. And really, this is going to be something I think as important now as climate change, as the economy, and other challenges facing our world. And in fact, I think the next time you go to vote, when we're all allowed out again, one of the things you might be asking your candidate is, what are you going to do to protect our global health? Next, please. So I'm going to go through an outline of this about why this is important, how prepared are we, what are the impacts and the practicalities for healthcare systems. I'm going to touch on research, treatment and vaccines, and of course talk about prevention and finish with something around policies that we might be able to follow. Next. So what are we actually preparing for? Well, pandemics are really interesting and important. They're large-scale outbreaks of infectious disease that can greatly increase morbidity and mortality. And we're all living through one right away now with COVID-19. They occur over a wide geographic area, and they cause significant economic, social, and political disruption. Again, this is all very relevant to all of you listening because this is happening as I speak. Next. Now, there have been quite a lot of pandemics recorded since the Middle Ages. You can see here, starting with the Black Death. You can read these tables at your leisure later, looking at the direct morbidity or mortality. The Black Death killed nearly probably up to half of the European population, and you can see the economic impact in the last column. But actually, in living memory, here, there are at least 2, Asian flu influenza pandemic and the Hong Kong flu. And if we go to the next slide, you can see another 4. So there's at least 6 or 7 pandemics in living history. So why are they getting on the increase? Next slide, please. And the likelihood of these have increased because of our behavior. We've got increased global travel and integration. We've got a lot of urbanization and changes in land use and exploitation of the natural environment. And this creates a new interface between humans and wildlife. Imagine you're in the Amazon and you build a new road. you're suddenly coming into contact with wildlife you wouldn't have come into contact ordinarily. Or you decide that you're going to bring exotic and rare animals to a marketplace where you introduce that animal to contact with human beings. And it's interesting, of the 335 emerging infectious diseases that have been identified, 60% are from animals, zoonotic in origin. Next. So how prepared are we for global pandemics? And there is, Oppenheim developed this preparedness index. I'm not going to go through it in detail, but it's really about how good is your public health infrastructure? How good is your physical communications, your public management capacity? How as good is your capacity to mobilize financial resources? And how good are you at effective risk communication? Next. And when we look at the map, the thing to say, when you look at this map, the darker colors are actually the least prepared, So when you look on this map, you can see that a lot of Africa is poorly prepared, some of Asia, and then parts of Latin America. And this is important. Next. It should concern us because there is this theory of spark and spread. So the spark is when the epidemic, a disease becomes an epidemic and might become a pandemic. And the spread is how easily could that happen? An example, if you had a disease that came from an animal into a human in an isolated village in the Amazon where there was no contact with anyone else, it would stay there. Whereas if you had, as we have had here, a disease that spreads to a human being where there are a lot of people who then go traveling, you suddenly get the spark and then the spread. Now, Europe and the US have high levels of preparedness for these sorts of events if they occur within their countries. And China has capacity too, but lags behind Europe and the US. But actually, there are geographic areas with high spark risk from wildlife species, including, as you saw on the map, Central and West Africa, which have the lowest preparedness scores globally. So we still continue to have a potentially dangerous overlap of this spark risk and this spread risk. Next slide. Now, recently, very recently, in the Lancet, this was published, which showed that only 57% of the countries they looked at had the functional capacity to prevent, detect, and respond to an outbreak of a novel infectious disease at a national and subnational level. And there were nearly 20% of countries, nearly a fifth of them, had low readiness and would require external resources to control an emerging infectious disease event. Why is this important? Well, we've seen nearly 7 in living memory, and most of you are on this call are going to live through another pandemic, and we need to get prepared. Next. We need intelligence, and it's called so-called situational awareness, which is a form of surveillance. We really need an accurate, up-to-date view of potential or ongoing infectious disease threats. And we need to have an up-to-date view of what resources we have, human, financial, informational, and institutional. Now, this may seem a little dry and bureaucratic, but it's absolutely vital if we're going to keep our eye on what's happening next. So, how do we know a pandemic is coming? Well, first of all, it requires that the healthcare workforce recognizes it and it presents as an illness and reports it rapidly. Now, this is an interesting point because Dr. Li, who was the ophthalmologist in Wuhan who reported the COVID-19 outbreak, where he saw these pneumonias, he reported it to the Chinese authorities, who made him write a letter to say that what he was saying was anti-state. So the reporting of this should be, in my opinion, above country level. You should be able to report it, for example, directly to WHO or another authority to say something's happening. Otherwise, the state could suppress it. You also need technical and laboratory capacity to identify the pathogen, because if suddenly you saw a lot, as we did with COVID, lots of pneumonias, you need then to get samples and test them. And you have to respond to suddenly a surge of clinical specimens as people get ill in a timely manner. Next. And why you shouldn't delay. Well, if we look at the 2003 SARS pandemic, a 1-week delay in applying control measures may have nearly tripled the size of the outbreak and increased its duration by 4 weeks. If we're better prepared, have better surveillance, better reporting, the SARS pandemic may have been much smaller. Next. Now, what about the impact on healthcare systems? Well, the problem is that when pandemics come, they cause a spike, a sudden spike in morbidity and mortality, and they can overwhelm health systems. And we're seeing this. We've had reports from Italy, we've had reports from France. I had an email this morning saying that a lot of hospitals in France are running out of ordinary medications that they need. And the other interesting thing about health systems is they get when they get overwhelmed, there are indirect effects. And from some of the pandemics, having a health system that's overwhelmed, so you can't look after other conditions, can contribute to a 2.3-fold increase in all-cause mortality, not just from the pandemic, but from other things. And during the 2009 influenza pandemic, there was an increase in acute myocardial infarctions and strokes reported. Next. The healthcare workforce is fragile. And even if healthcare workers do not die from the disease, and we've seen many of those being reported in this COVID epidemic, their ability to provide care may be reduced. And in some countries at the moment, up to 40% of the healthcare workforce, and you can see here, and it was the same in the severe flu epidemic, might be unable to report for duty because they're ill themselves. They need to care for ill family members. They need to care for children because of school closures, and they are afraid to come to work. Next. And this issue is much bigger than just healthcare workers, because pandemics have significant social and political consequences, which of course will impact on healthcare systems. That you can have clashes between states and citizens. We've seen what happened in India with the migrants trying to leave when the state said there's a lockdown, and a lot of the citizens tried to leave. The state capacity gets eroded. Yesterday, the British government have been saying that we're going to increase ventilator supply, and we're going to increase the number of tests. They've written off the debt for the NHS, but the state capacities, bit by bit, to do things can get eroded. Population displacement gets driven, and people are moved from one place to another, or not allowed into various countries. There's heightening social tension and discrimination, which we've seen, and also fear-induced behavioral changes. All of these things have impact on our social and political life. Next. So we have to prepare also for an economic shutdown. One thing we must try and maintain are health systems, but there are major employment issues, and we've seen that many people in Europe have lost their job, especially those working in small businesses, and others are now having to work from home and trying to change the way that they work. Governments have closed land borders and restricted the entry of citizens from affected countries and migrant workers. And this is massively important in many countries where you're dependent on migrant workers to pick your fruit crops, to cut your flowers, to pack and do manual laboring jobs. And if you can't have those migrant workers and you can't do these things, the economy starts to become more and more eroded. The private sector can disrupt transport, trade, travel and commerce, cancelling commercial flights and reducing shipping and cargo services. There is a report this morning about the number of people who are looking after our ships, sailors on boats, who have got very little health care and are fearful of COVID-19 disease. Next. What about the cost of selected emerging zoonotic diseases? Well, you can see here that from this, the big green blobs are the size of the epidemics, of the pandemics, and the costs. And you can see SARS cost around $40 billion overall. I think that when this COVID-19 is over and we put this into the cost, these will be at the very, very bottom of the graph, and we'll have a huge green blob way off our screens. It's going to be huge. Next. Now, this is what people do for pandemic preparedness. I'm not going through all of this, but the response activities. But I just want to say that in the pre-pandemic period, it's really important that things are done. So before the next pandemic arrives, we really need to have good public health workforce training, planning, stockpile building, and do simulation exercises. For any of you, those of you listening who are in healthcare, I wonder how many of you have ever gone through a simulation exercise for a global pandemic. Most of us with COVID-19 are learning as this unfolds. Then as the pandemic starts, the spark period, there's lots more that we have to do, especially about pathogen characterization. And then when it's spread, obviously, we need to think about vaccines, antivirals, but mainly about care and treatment. Next. So some of the practicalities of preparedness for healthcare systems. We really need good procurement and supply chain management. And people have said that logistics is everything in a pandemic. Really, we got to make sure we have adequate stocks of personal protective equipment and essential medications. And all of this is being stressed by this new epidemic of COVID-19. And we have to enable, and I put here, equitable access to new diagnostics, therapeutics and vaccines during health emergencies, and I applaud what WHO are doing in terms of making sure that we get adequate information around all of these and pushing the way forward so that we can get this access. Next. We have to scale up laboratory capacity and other surveillance capabilities and increase the readiness of health systems to care for a large number of seriously ill patients. We have, and most of Europe, have emptied our hospitals of outpatient clinics. We've converted these into COVID clinics. We've emptied a lot of our wards of patients that can be managed, have to be managed at home or by families, and we've converted those into COVID wards. But we really also need to safeguard the healthcare workforce. I've just outlined before why that's important. And one of the most important things is to improve communication and coordinating strategies. Rumor around what's caused COVID, what treats COVID, what helps with COVID is abundant. And the internet is full of all sorts of strange things which have got no logic, no truth behind them. So part of improving communication is not just coordinating the truth, but it's also making sure that we don't fall into the trap of believing in rumors. Next. Research. Well, we really have to deliver clinical useful research in a very narrow time frame because it's during this infectious disease epidemic, we require pre-planning even before the disease has gone from into an epidemic and then into a pandemic. And the problem is we have a very narrow window of opportunity, and time and again, that narrow window is missed. Next. So we have to prepare for drug trials. And as you saw from Meg's presentation, lots of drug trials are being done at the moment. But, and it's good that the regulatory authorities have changed to approve studies rapidly. You don't have to wait 6 or 8 weeks to get approval now. Pilot trials have to be scaled up to full trials if the pilot looks like it's got some validity. We must also think about doing combination therapy, not just single drug trials, and also look with these diseases such as COVID, drugs that have an antiviral effect, which may be more useful in mild to moderate or early disease, versus anti-inflammatory effects, which might be more useful in severe disease. Manufacturers should be ready to upscale constantly. They should always be ready to upscale. And when things start to go from epidemic to pandemic scale, they should be ready to manufacture large volumes of drug. And coordination for drug trials is absolutely crucial. Otherwise, we can have lots of different trials being performed all over the world without really any coordination going on or pooling of data. Next. Vaccines. Now, there's a proactive and a reactive approach to vaccines. So if you look at the top half of the diagram, these are 4 pandemics: influenza, Zika, Ebola, and SARS. The little spark is where they started. The epidemic was, the pandemic started, and in the yellow areas where it reached the peak. Now, if you look in the yellow area and drop down to the bottom of the graph, you can see that usually what we say is, we're in a pandemic now, let's do some preclinical data on a vaccine, let's look at candidates, then let's put the candidate into clinical operation, which I know with COVID now, people are being, there is a vaccine in clinical use, and then if it's useful, we get to scale up a manufacturing. But often all of this is a bit late, but because by the time we have effective vaccines, the pandemic is on the way and it's going down. What we really need to do is to shift the time frame into one where we have scale up a manufacturing when the pandemic starts, so we can vaccinate people and limit its impact, which means that all the time people should be looking at various zoonoses and seeing whether or not we can have any preclinical data on vaccines that might be useful, and getting them into the clinical scenario as soon as these outbreaks start. Next. Vaccine preparedness. So identify the candidates early. We have to speed up vaccine development and scale up production. And this means vaccine manufacturers may have to take production risks. In other words, they may have to start producing a vaccine in large doses, which looks effective. And then maybe if the clinical data, the big clinical trial comes back and says, sorry, it wasn't very useful, have to say, okay, we'll have to stop the manufacture of that and start on the next one. So they may have to take production risks. We also need capacity for the so-called last mile delivery to rural areas, which means that nobody must be left behind in terms of getting access to a vaccine, and we have to be able to deliver them. And also populations have to have a willingness to adopt a vaccine. And although you might say that's crazy, everybody would like a COVID-19 vaccine now if it worked, we've seen the change in attitude to vaccines over the last 10 years. For people to be cautious and wary of them. Next. So there is a coalition for epidemic preparedness innovations, and they've made an urgent call for $2 billion to support a vaccine. And I really hope that we can get one as soon as possible. Next. So prevention. Prevention, well, we need to do several things. One is to get data from outbreaks at the animal-human interface as soon as possible, understand the determinants and risk factors through our research, and we have to devise and test mitigation strategies. And there must be policy uptake by every government in the world. Next. And this is one thing that people have bought into. It's the concept of One Health. And it's like where we started to accept climate change and environment as an important issue. The concept of One Health considers human health, animal health, and the environment to be fundamentally interconnected. Next. So One Health activities. We have good surveillance of zoonotic pathogens, of pandemic potential at the human-animal interface. We model these evolutionary dynamics. Is this zoonosis going to turn into a pandemic? We do risk assessments, and we understand this interplay between environmental changes and pathogen emergence. Next. And here's a whole list of organizations, including WHO, who endorse this One Health approach, and other groups that are doing a lot of research efforts in the One Health approach. Next. So finally, policy. So many of you probably don't know about the international health regulations, which were brought out or revised in 2005. These say we should prevent and protect against and control and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks, and which avoid unnecessary interference with international traffic and trade. So this is trying to say we need a public health approach to prevent a pandemic spread. And there's WHO and the Global Preparedness Monitoring Board have said, yeah, we've made some good progress with this, but important deficiencies in coverage still exist. So we really all should sign up to the IHR. Next. And finally, this is something that is called the Sendai framework, which is complemented by the IHR. And it comes back to me from the very beginning when I said, next time you go out to vote, ask them this. What do you think about the Sendai framework? Because this integrates our infrastructure, climate change, and economic considerations into disaster management plans and promotes inclusive policies that protect vulnerable populations during all the phases of mitigation, preparedness, response, and recovery. If we had this framework globally, if everybody signs up to it, next time a pandemic comes along, we may be much better prepared. Thank you.
Thank you very much, Anton, for a fantastic presentation, and terrific to see both the historical perspective, but also this notion of One Health and how the health of animals, humans, and the environment can all be interrelated, as well as the issues around economic, social, workforce, politics, and policies. And that was a really interesting perspective. Thank you. Two specific questions to clarify before we move on to the final presentations, one in relation to preparedness and one in relation to tuberculosis. In terms of the preparedness, a couple of questions have come in asking if you could explain the fact that even though countries such as the United States of America and countries within Europe that on your map had high levels of preparedness, they're still facing a difficult time at the moment, and also high mortality rates in relation to COVID-19. And the second one was in relation to tuberculosis, knowing your expertise in that area, if there's any evidence in terms of BCG and its preventative effectiveness for COVID-19. And equally, on the other side of things, enhanced risk for people who have TB or latent TB and also living with HIV. Thanks, Anton.
Yeah, well, thanks. Yeah, they are very well prepared for US and Europe for pandemics that occur within their own countries. And this is very interesting that this has appeared, and I agree, that we, especially in Europe, have not been very well prepared. And I think that one of the issues that has happened is that in spite of a lot of the warning signs that governments have taken on a more wait and see policy with the COVID-19. And I think that in future, they have learned a very serious lesson. I mean, what is really needed, and everybody's been saying this and working very hard, I don't know, distract away from the works and efforts that have been going on, is that the strategy that China developed should have probably been implemented in a much more rapid way. And as I said, with the SARS outbreak, a week or two of delay, and you suddenly get a much bigger issue. Also, I think that we're at a point in the world where there's so much travel and tourism, travel for trade, etc., that it's quite hard to prevent diseases spreading into countries. And once they're there, as you can see, they take off very rapidly. And we have to think about what the impact of quarantining whole populations is overall. And I think that lots are going to come out from this COVID pandemic. We're going to have a lot of research into actually how could we have done things better and what should we do next time. As far as tuberculosis is concerned, I know no evidence that BCG protects against COVID. And the other thing is, do people with tuberculosis have enhanced risk? Well, obviously they have the same risk if they have diabetes, heart disease, but they often have lung disease. And if they have bad lung disease, then it's not the TB itself, it's the lung disease. So I think that we don't know the data. We have no data as far as I know, but I would be very cautious with people with tuberculosis, with lung disease of moderate to severe, and I would ask those patients to, as we have here, to self-isolate. But I've no evidence from the pandemic that that's true, but I think that makes common sense to me.
Thanks, Anton. And one final question that's just come through is in relation to the preparedness, and the comment is that actually the response to COVID-19 has prompted countries such as India to strengthen their response and become better prepared. And another question has come in for countries that are not very well prepared at the moment. What would be your advice to people to call on their governments to, or other policymakers to put in place?
Yeah, well, India has gone through a very severe lockdown, and personally, I know what it's like there because my brother is stuck in a hotel room in a small town in India at the moment. Yeah, so they have done a complete lockdown. However, there have been consequences of that. As I said, the migrant workers all were trying to rush home and congregated together. So I don't know what's happened in the rural areas, if there were sort of mini outbreaks of COVID amongst the gatherings of those people when they were trying to get back. But yes, they really, India has enforced quarantine as one of their major measures. The other countries that don't have that, well, I think the thing is that this has become a global issue, and other countries, if they don't have the resource and facilities, should be seeking help from those that do. And there are ways from this happens, as there are global preparedness groups, international groups around the world. The World Bank has been involved in One Health, and I would suggest that expertise can be shared. I mean, WHO, as you saw from Meg's presentation, has a huge amount of expertise, and they are advising countries all the time. So I think that what it is for governments to reach out to other governments to say, can you help us with resource? Can you help us with advice? And can you help us with practical things like drugs, medicines, etc.
Thank you very much, Anton. Now handing over to our third and final presentation for the webinar this morning, Dr. Olivier Nawaj-Chikung. Thank you for joining us, Olivier. He's at the front line of the response here in Geneva, in Switzerland. He's a senior resident in the HIV unit of infectious diseases at the Geneva University Hospital, and he's been working in the HIV field since 2015 with Professor Alexandra Kalmi. Dr. Nawaj-Chikung is a Belgian of Congolese origin in the DRC, and he did his medical studies in Belgium at the Catholic University of Louvain and his postgraduate training here in Geneva in Switzerland. Thank you for joining us today, Olivier. Over to you.
Thank you for giving me the opportunity to speak about this subject and to share with you the experience we have with HIV, with people living with HIV in Geneva in the COVID context. The management of HIV patients in this context raised many questions, both from patients and from a medical point of view, on a pathology that we discover day by day, with also few therapeutic options for which there is few or no evidence on efficacy. Next slide, please. In patients living with HIV, there is currently no evidence that for higher infection rates compared to HIV negative people, we can ask the question if the risk is not higher if untreated HIV infection, and or with people with CD4 counts below 200. We might assume that they may be more at risk, but we have no data. And we also have the fact that some people living with HIV have risk factor for severe illnesses. I will come back in a few seconds on it. And there is also a question about boosted PI containing regimen therapy, and the question to know if they act as a protective prep, but we also have no data and we cannot assume that. For risk factors for COVID-19 severe illnesses, the literature shows that there are many factors. Age seems to be a factor for severe illnesses. For patient age more than 65, people who have cardiovascular disease, including hypertension and diabetes, people with chronic lung disease, and also heavy smokers, which usually have also a chronic lung disease, people with immune suppression, and those with oncologic treatment. Next slide, please. For people living with HIV, there are many questions that raise from this situation. Questions from patients about the risk and the risk related to their HIV status. As in general population, people face anxiety from this situation, but maybe exacerbated for HIV positive people with the uncertainty about the risk related to the HIV status. And it also raised question about drug availability and the follow-up of patients, while many countries have implanted more or less strict measures in the policies. And another issue could be the voluntary counseling and testing, and also the care of people needing post-exposure prophylaxis. Next slide, please. There is an interesting survey in Hubei and other regions made for people living with HIV in February, in which 32% of all respondents were not carrying sufficient antiviral medicine, and some could face stockouts also. In Hubei province, 64% reported difficulty accessing RVs due to the restrictions. And talking about anxiety, 28% respondents were in need of social psychological support. That highlights the situation many people living with HIV might face now with all the restriction policies and all the situation related to COVID-19. Next slide, please. To understand the measure we took, just a brief look on our HIV unit structure and activities. We have about 800 outpatients, and our clinical activities are mentioned here. There are medical consultation, also the hospital for complete cases, follow-up of hospitalized people living with HIV, and for RVs, until recently, we provided the RVs by a dedicated pharmacy at our reception. I will explain you later why it was important for us to have also that system. Our consultation, we have also post and pre-exposure prophylaxis consultation and voluntary counseling and testing consultation also. Next slide, please. To address some of the issues already mentioned, one of the issues was the risk related to HIV status and anxiety. Next. What we did, many patients called us just to see if they were more at risk and just try to have some answers. What we did is to give them explanation by phone and remind them that they had to follow all the recommended measures established by the government. Next, please. It's important for us that all patients are contacted by phone, and to date, no medical consultation were cancelled. They were at least contacted by phone. Next slide, please. For the risk of loss to follow-up of some patients, next. We kept all the blood sample, exception for patient decision related to anxiety or fear going out, and vulnerable people if it was only a routine test. And in that way, we favor telemedicine for result and consultation, and at least a phone call for a patient. Next slide, please. For risk interruption of treatment, we assessed something next. As we have our own pharmacy in our unit, we could have checked prescription and lost drug supply, and we called patients, especially those who are nearly out of stock, and we called all vulnerable patients just to manage to give them medication for at least 3 months. Next. For the medication, there were many possibilities. Prescription, to send a prescription to the neighborhood pharmacy for RRVs and other current co-medication. And also we settled home medication delivery whenever it was possible. Next. To protect vulnerable people, we recall them the measures established by the government. Next. Okay, go ahead. For those vulnerable people, we tried to postpone all the routine follow-up and keep the phone contact. Next. Favor telemedicine also. Next. And try to guarantee all medication delivery so they are not out of stock. Next slide, please. And for VCTs and post-exposure prophylaxis, next, we postponed all routine testing for asymptomatic people without risk exposure. Next. We maintain an outline for risk evaluation and counseling in partnership with some association in Geneva, like Checkpoint or Groupe SIDA Genève. Next. And we maintain consultation and testing for people with risk exposure. Next slide. Here is a table. I won't go in details in it, but it's the co-infected HIV and COVID-19 hospitalized patient. From March until yesterday, we had an overall hospitalization of 985 patients, including 4 HIV patients. Most of them were male, except one. They were age of at least 55. They were all on RRVs with good virological control, and they had, most of them were lymphopenic due to COVID-19, but had a good percentage of CD4 count. Many of them had risk factors for severe illnesses. One patient required mechanical ventilation in intensive care unit. He was discharged from intensive care 48 hours ago and is improving. And one patient was discharged. You can note that most of them had some treatment added with lopinavir, ritonavir, and hydroxychloroquine according to our guidelines. One patient who was already on elvitegravir cobicistin boosted received darunavir, but with no evidence of efficacy. Next slide, please. So all patients remain on their current antiretroviral therapy, but we've added lopinavir, ritonavir, or either for one patient darunavir for the severe COVID-19. And of course, there is a question about drug interactions while adding those molecules, but we checked all the interaction using Liverpool websites, HIV drug interaction, and the dedicated COVID drug interaction. Next slide, please. To date, as far as we know, we have no patient who seek medical consultation for COVID-19 associated symptoms during the epidemic period. Maybe some have not sought medical examination with mild symptoms, neither being tested, but to date, we don't have any other patients with COVID-19 in Geneva. Next slide. In conclusion of our experience, first of all, we have to say that COVID-19 did not seem to disproportionately affect people living with HIV. More data maybe are needed. we addressed some challenges. What was important for us is to guarantee people to continue the follow-up and the access on ARVs by phone consultation, telemedicine, and also a settled home medication delivery system. We also think it was important to maintain VCTs and PEP after risk exposure. And all the action we took were really appreciated by the patients when we called them. Next slide. And with that, I want to thank you for your attention.
Thank you very much, Olivier. It's absolutely fascinating to see the step-by-step details of how you've managed the response here in Geneva. Can I ask you just one question before we move to the Q&A session more broadly? But knowing what you know from what you've seen here over the last few weeks or even months, what would be the one piece of advice you would give to colleagues in other contexts that you would have done differently or done sooner that you've learned from your experience so far?
It's difficult to, in that situation, to give advice, but I think the most important things, as I already mentioned, is to keep people living with HIV to try to ensure that they have access to the treatment, but not only on the treatment, but we have to take it globally. And just because for everybody the situation is anxious, and maybe to be proactive and to call patients. We started to call all patients who were scheduled without canceling any appointment, and just to see if patient had a question and just explain also the situation, because it's not clear for anyone and anybody. So we try to do the best.
Great, thank you very much. So now I'd like to open it up for the general question and answer session. We are running short of time. We have only 10 minutes left from the original schedule, but if at all possible, I'd like to ask the panelists to remain for an extra 10 minutes, if we could borrow just slightly longer to respond to some of the questions. And also just to mention to everyone, there are a lot of questions coming in, many of which are highly relevant and really interesting. And we also have the portal recently launched on the IAS website, and we will update that with additional information in response to the questions answered, but also those that we didn't have a chance to get to on the webinar today. So if I can pose a question actually to all the panelists that's come in. It came in actually very early on, and it's from someone living with HIV who's commented that she hates to be passive in the response, and also that herself and other people living with HIV now consider themselves as part of the health workforce in terms of peer outreach and responding to the services needed from within the community. Does the panel have any advice for what someone living with HIV can do to protect themselves and their peers? Is there anything differently they should do as opposed to everyone else in light of the response to COVID?
So I might just say that the HIV response is something that the COVID response has learned from. And I think as far as people living with HIV are concerned, first of all, you have to assess your personal risk. So obviously, if you're over the age of 65 and have got or got comorbidities, then any sort of face-to-face volunteering would be very difficult because of the risk to you. But if you're not in that category, then there's lots of things you can do is support elderly people. Obviously, you have to keep personal distances. And we have groups here, community groups, where elderly people have their food delivered. They get phoned, or they get people taught to them online. And that's including elderly people with HIV, of course, because a lot of the patients in Europe, US, and other places are now over the age of 60 years old. So there's lots of inventive things you can do, utilizing experience of HIV communities, providing good information, providing chat lines, etc., etc. So yeah, be inventive and do as much as you can, but within the constraints of self-preservation here, because you have to take care of yourself and your loved ones and your families.
Thank you, Anton. Maybe a question specifically for you, Meg, that's come up in relation to anecdotal stories we're hearing about rise in gender-based violence that maybe coincide with the recommendations for people to stay at home. Is there any guidance that we have currently from WHO or can look forward to in better responding to this risk? And also particularly with the well-being of lesbian, gay, bisexual, trans and queer persons who maybe no longer have a sense of home or don't have that safe space. Is there any recommendations or knowledge from WHO on that aspect at this stage?
Yeah, I think this is a rising concern and certainly something that WHO is taking seriously. And I know with many of the UN partners, including UNDP, UNFPA, I will find the statement that there has been some statement and guidances that have come out through the UN co-sponsors around this concern. And our guidance really, I'll go back to, is likely in development, and I'll have to go back to our website to see, because if you go back daily, there'll be additions as they come in. But the suggestion is, and we know this may not be possible in many instances, is but to really identify other places where one could be. You know, being at home doesn't mean it has to be your own personal home. Are there places that you could quarantine with either friends or somebody who you know is well, etc. And or I think there's going to be a need for local governments to ensure that there are safe places, whether it be a church, a gym, or other locations, a safe place. Because being in lockdown doesn't mean you have to be in lockdown with the person who is abusing you or being where you feel unsafe. So if you do feel unsafe, it's about identifying a safe place that you can be at. So more to come in there, and I do know that it's a challenge that we need to address more aggressively as we move forward. Thank you.
Great, thank you, Meg. Maybe a question here for Anton and Olivia, a question that's come in terms of preparedness and also responding to mental health issues that have emerged in relation to the response to this pandemic.
Yes, about the mental issues, what we did, except calling people, we also have our psychologist and psychiatrist a consultation that is aware for patients who need it. They can have also a phone consultation or telemedicine with our consultant here, because it's an issue that we have to take care of.
Yeah, we've done the same. We've used the media, basically, of video conferencing, teleconferencing, to make sure that people have got access to the care that they need with mental health issues. There's also a big issue about connectivity, about loneliness, and that, I think someone mentioned that earlier. And again, if people can make sure they reach out to family members, friends, others that they know that might be lonely, by telephone, by video conferencing, etc. That's really very helpful to improve mental health. And the elderly, the isolated elderly, are also an extremely vulnerable population. So we all have to do our little bit for that.
Great, thanks Anton, thanks Olivia. And just to mention to the participants in the webinar, we will be showing a poll shortly that has some ideas for future topics for this webinar series. As we've mentioned, we plan to have one every 2 weeks while there's still a need and an interest in this. So please do express your vote in terms of the most timely topics that we could convene a webinar on. The poll should now be on your screen right now. A question has come in terms of quality control in relation to, for example, the manufacturing of PPE equipment and some of the alternatives emerging there, or also some of the new diagnostics or new treatments and new innovations coming so rapidly. Perhaps for you, Meg, are there some stages in place or some control measures in place to monitor the quality?
Yeah, thank you very much. And that's a really important question. And we have a group, our medicines and diagnostics pre-qualification group, that is looking at all of the new, all of the either the commodities coming in and doing fast tracking on these. In particular, there will be something coming out next week around expert and the safety and the issues about needing a BSL-3. I think there were a couple of questions on the Q&A about, do we know the sensitivity and specificity, not only of the nucleic acid testing, but some of these new rapid tests, which are either antibody tests or eventually will have antibody and antigen tests. And certainly all of these we would want to see and would likely come through a rapid process with a stringent regulatory authority, meaning either WHO, European, or the FDA. So yes, there is an approach to try to make sure that they're of the highest quality, but certainly without holding things up, and that there are rapid reviews. And in times when, you know, lives are on the line, there are often waivers to be able to use what's available to do the best that they can in a situation where we want to save as many lives as possible. So yes, active group working on that at all times. Thank you.
Great, thanks Meg. And one more for you at this stage as well, just in relation to emerging evidence about the effectiveness or lack of evidence about the effectiveness of the different approaches to lockdowns in different countries. Does the WHO have a position on that, and is there data to support the best approach to a lockdown situation?
I don't think I'm in the best position to answer that question, and that would be to the emergency team, and I'm happy to go and ask them. But certainly, the approach has been from WHO to test, and do the responses to the 4 C's, ramping up and using isolation and self-isolation for people who have symptoms, quarantining for people when we have contacts. And I think this reduction of and staying at home, I think has been part of the approach that has been successful in flattening the curve. And the approach with flattening of the curve, as you know, is to ensure that the public health systems, the hospitals, et cetera, have time to be able to take in the cases that are coming in. And what we've seen in places such as Italy and others, when they're overwhelmed with the number of cases coming in every day, it just maximizes it makes them unable to handle the severity of the cases in the way that they would like to. So, but I would, in terms of the benefit versus non-benefit and how to do it properly, I would defer to the colleagues in the emergency group. Thank you.
Thank you, Meg. A question now in relation to the Solidarity trial. I believe this is best suited for either Meg or Anton, but could you firstly explain it in more simple terms for a non-clinical audience, some of whom are on the call? And also, could you give an indication of when we can expect the preliminary results?
Yeah, so the Solidarity trial is a trial that's looking at 4 different medicines. Remdesivir, which was developed for Ebola and was used in China and was thought to have some good effect. The other is the chloroquine or the hydrochloroquine, which are drugs used for malaria and also for rheumatoid arthritis, etc. And then there's the lopinavir, ritonavir, or Kaletra, which we know, as well as interferon. And those 4 different drugs will be tested in what we call a trial where it can be used rapidly in the clinical hospital setting, and that there is the opportunity for these hospitals to change over midstream if they need to new drugs if something is found to be more efficacious than others. As it just got started last week or a week and a half ago, but they're enrolling. I heard yesterday, already have 200 persons enrolled right from the get-go. I would imagine we're going to need at least 1, 2 to 3 months before we really see which are the drugs that show the most promise for both reducing mortality and reducing severity of illness. Thanks.
Thanks, Meg. And just to remind everyone that the poll is up on your screens here, just to be clear that all of the webinars would focus on COVID-19 and HIV, but also with an additional lens, for example, on the impact on frontline healthcare workers, adolescents and youth. DSD there stands for differentiated service delivery, which relates to my next question. That's what reminded me of that. Or one on stigma and discrimination, one specifically on testing within the context of COVID-19 and HIV, on general practice and clinical updates, or other, if you have any other suggestions you'd like us to focus on. So just being clear that all of those topics would focus on COVID-19 and HIV. So the next question here is in terms of what recommendations can WHO give in relation to multi-month dispensing for unstable patients, and does WHO have any advice in relation to ensuring that very sick people with opportunistic infections or comorbidities and how they can continue to access appropriate care?
So I think what we have in our guidelines around using multi-month prescription is not only for people who have had multiple viral loads that are suppressed. Stability can be measured through lack of new clinical infections and or increasing CD4, and stability also extends to adolescents, children, pregnant women, lactating women. So I think we have extended over the past several years what stability means. And so it's important that we try to make multi-month prescriptions and multi-month dispensing of drugs available to as many people living with HIV as possible. And if there are challenges, we want to hear about them. Secondly, I think people who are not on antiretrovirals should be on antiretrovirals. And the best we can do at this point is try to ensure that people have access to the antiretrovirals, access to testing. If people have other comorbidities and opportunistic infections, I think it's very important not to stay at home and suffer from those other problems, but it's important to link into your healthcare provider and get the advice needed and follow what is suggested of your healthcare provider to come into the health setting, either at a different time, when with a mask, under situation where you can keep your physical distance and safety, but it's important not to allow other infections and to stay at home and to avoid a healthcare setting when that could put you at risk as well. We just don't have enough information about HIV and COVID yet. We see the 4 cases that were presented. We have about 10 other cases. We need much more information before we can give you really clear advice. So more to come in the future. Thank you.
Thanks very much, Meg. We're almost at time, so I'd like to just ask each of the panelists if you'd like to just say one remark in closing for today's webinar, and just reassure everyone that for the comments that have remained unanswered, we'll address those through the portal on the IAS website. So perhaps starting with you, Olivier, and then Anton and Meg, just one final comment from your perspective.
Yeah, for our perspective, it's, I already explained it many times, but it's really, really important that to manage that the care of people living with HIV is not too much influenced by the COVID situation in terms of HRV access and also of follow-up, and it could be done as we explained with telemedicine and phone calls, and also address all psychological issues that are present for everybody and not only for HIV, people living with HIV.
Thank you, Olivier. Anton.
Yeah, I'd like just to call on the broad HIV community who have done so much since the beginning of the HIV pandemic to help show the world how much we can do and contribute, but whilst keeping ourselves safe. So yeah, let's roll up our sleeves and get going with this, as many of us already have done, and I thank you all for that. But there's more to do. So and thank you for listening anyway.
Thank you, Anton. Meg.
Thank you. I just want to say, reading through the comments, etc., I've seen so many interesting questions and interesting areas that we need to address as we move forward. This is unprecedented times, an unprecedented time to share information. So at WHO, we're very open to hearing your experiences. So thank you very much. I was just informed that there has been several seminars from our emergency group on COVID and gender-based violence. So I will share those forward with the organizers so that you can make them available. So as we speak, somebody else might be doing might be addressing one of your questions. And I think it's wonderful that the IAS has this portal to help connect all of us. Thank you very much.
Thank you very much, Meg. And thank you very much to our three speakers for interesting and really timely and informative presentations, and also for staying to continue to answer the questions coming in from the audience. I'd also like to thank the Swiss Agency for Development and Cooperation, SDC, and Merck Sharp and Dom, MSD, our donors. Without their support, this webinar and the series wouldn't be possible. And I'd also just like to let all participants know that you'll have the opportunity to fill in an evaluation survey just at the conclusion of this webinar. We really value your feedback, and it's important to us so we can continue to improve the series. So please do take a moment to complete that survey. And lastly, thank you very much for joining us this morning or this evening to colleagues on the other side of the world. Please stay tuned for our next webinars that are coming up in the coming weeks in this series on COVID-19 and HIV. Thanks and be well.